I'm going to do my best to work through a bit of a sort of a throat problem, so apologies. First, thank you for the opportunity to share a little bit about our experience in building information infrastructure companies in other industries. And in many ways, why healthcare is very much the same and very much different. So trying to understand the differences. So I've had the good fortune of building companies in a number of different industries, including telecommunications. My last company was the big data leader, big data and analytics leader in the telecommunication industry. Every telecom company more or less in the world runs that. So Verizon runs it, T-Mobile runs it, Sprint runs it, RT in India runs it, Vodafone all across Europe runs it. And that platform, if it goes out of service for somebody like T-Mobile, it takes their entire nationwide network with them. It's pretty important that it delivers accurate results sort of continuously. Through that experience and some experience of my team in the financial industry, we thought about how to come to the healthcare problem. My wife is a physician, I am not, but I've been around information problems my whole life. And I want to share a little bit about that experience. And we talk a lot about today in healthcare trying to take evidence in what we invest $30+ billion a year or into as a nation. The great basis of healthcare research, much of which goes on in institutions here like Mayo, and turning that evidence into practice and good quality practice. We don't often talk about the opposite, which I think is an opportunity that we've seen in other industries and we're beginning to see in healthcare as well, which is turning practice into evidence, because it is a cycle. In most other industries, that's how they create a quality improvement process. And so I'll tell you a little bit about and take you back to quite literally a presentation I gave about 6 years ago in the telecommunication industry, just as sort of a reference point. So most of you will be familiar with statistics like this, and we generate, according to Eric Schmidt, who's the good fortune of now being associated with Mayo Clinic as a trustee, that we generate as much data in every 2 days as we did up from the beginning of time until 2003. And that pace is only accelerating. The real question is what are we going to do with all of it? And in particular, what does it mean for healthcare? My own experience in other industries, volume matters. Quality matters in healthcare, and the connection of data matters in healthcare. So it's just not about how much you've got, but it's about what you do with it. And in healthcare, we've not yet been good at applying it and applying it at scale. So a little bit of just maybe back about myself. I've got a math background, a computer science background, a business background. I started my career at Bell Laboratories. I wore shorts 300 days a year and had hair down the middle of my back and earring, which my parents didn't like. This is one of the few accelerators I can come to and feel comfortable in a suit, because I'm supposed to be wearing jeans if I'm at an accelerator. So, most of my tenure has been, as I say, in information infrastructure. So most of my work and academic work was doing that, and I've done that across 4 different industries now. So in computer-aided engineering design, which has highly complex and heterogeneous data, in communications, in IT, and as I say, now in healthcare. So I've done just a little bit about anything, and for those entrepreneurs in the room, a lot of people ask me as an entrepreneur, pardon me, can you start and be successful as an entrepreneur at a big company, working for IBM or Mayo Clinic or AT&T? The answer is absolutely. It's a great place to start an entrepreneurial experience. You can make lots of mistakes. My sister has been successful independently as starting businesses, and I describe her, to her chagrin, actually I think it's a benefit, as an amateur entrepreneur. I sort of describe myself as a professional entrepreneur. Anybody know what the difference is? Here, guys. I made more mistakes. So I've got a lot more scars. She's doing a great job, actually, not making the mistakes. So big companies give entrepreneurs the opportunity, the Mayo Clinics of the world and IBMs and others, to learn their trade and to candidly fail and take risk without having to put your family at risk or put your savings at risk. And so I started my entrepreneurial career at a big company, which was AT&T, and I've sort of developed that. And what I found is I like starting businesses where there's no staff and just an idea, and no team, because putting together a team is a craft, building a technology is fun, and then ultimately making others happy and having an impact in the market. So I ended up growing about 5 businesses internal to a large corporate structure, all starting at that start nowhere. Most of those ending up in greater than 500 million of sort of sales and turnover, mothballed one along the way. I've had 6 external ventures, which I've been associated with in an executive position. Crashed and burned one, so my first company I wrecked. I spent all the money on the fun stuff, the technology, and realized it was going to take me 3 times as much money to actually market and sell it. So, and I've got a couple of ventures that are still growing. I always try to put a little bit about what went on in my life. I lost my first marriage with my first company. I paid too much attention to it, so entrepreneurship has a cost to it, or can have a cost if you don't pay attention. So I'm on my second marriage, definitely not trying to lose that one on these other companies, so I've learned a little bit. Some say food, some say family. I had a heart condition. I had open heart surgery here, quad bypass at 44. Thanks to Mayo Clinic, was in and out in 4 days, went home, put on a suit, and went out to dinner. And I said, when do I need to come back? And a good surgeon here, Rocky, if anybody knows, a thoracic surgeon, said, a year. I said, I only give 90 days of warranty on my software. You guys are doing a much better job. You give me a year warranty on my heart surgery. So, but Mayo Clinic helped me through that. So this institution's always been, no pun intended, close to my heart. I've got a 10-year-old, which I got to figure out how to pay attention to while running small companies. So entrepreneurship is fun. It comes with an expense, is my point. But it's absolutely great to be able to impact industries. So is there a connection between the communication industry and what happened in its development in finance and in healthcare? I absolutely think that there is. Importantly, those 3 industries, and there are others that are developing in somewhat the same way, is this need, I think, to apply data and information at enormous scale, touching every person's lives. Okay, so I got to see the mobile telecommunication industry go from quite literally hundreds of thousands of people with a cell phone to literally half or more of the world. So there are almost, I think now, more devices than there are people in the world. So, and in the next few years, we'll be nearly at everyone in the world having some sort of mobile phone connection. That's at scale. That touches every single person's life. Healthcare is sort of one of those interesting things as well. It touches everybody's life. And therefore, if we're going to apply data, we're going to have to do it at some incredible scale. And it's got to be at the point of service, where you touch the person. Lots of industries like manufacturing, it doesn't touch people at the point of service. So there's some glaring differences, though, in those industries. So, in telecom terms, we think about petabytes of data a day, which is, just trust me, a lot of data. Okay, I'll give you an example. So, in some, thanks to some of us are more familiar now, thanks to Mr. Snowden and the NSA. But in a mobile network, it's not uncommon now, a national network like AT&T, to save every single bit that goes across the entire network every day for perpetuity. You save all the data. So it's every voice call we've made, every website we've ever browsed, everything we've done on the mobile network is captured and persisted for perpetuity. Now, that's a lot of data. That's a big data problem, okay? The question is, what are they going to do with it? The NSA had some ideas, I guess, but so, in finance, they talk about terabytes a day. Some places may be about petabytes, but lots of big data. Healthcare doesn't have a big data problem. Okay? It doesn't enjoy one yet, believe it or not. Those industries do. It is a complex data problem. Data in healthcare is very different and very hard to assemble, much different than the structure that exists in finance and telecom. And the telecom and finance industries think about nanoseconds. So I work with a proprietary trading firm, sort of as a hobby, that trades algorithmically. Okay, so they trade algorithms and stocks every day. They literally are worried about the time in a switch, an internet switch, where 100 milliseconds is the average today. They've just invested in a company that'll take the average time port to port on a switch to 3 nanoseconds. They're worrying literally about nanoseconds. Okay. Now, healthcare, again, probably not the point today. We still have data from CMS that we get a year after the claim was made. We need to improve that, but it's not yet a real-time data problem. And today in telecom, there's hundreds of applications and probably tens of thousands in finance. What we'll find, I think, in healthcare is millions. So if you go on. And the transition to those industries has been about 10 to 15 years. I believe that healthcare is going to advance and build on that, and probably in the next 5 to 10 years, we'll see a transformation. If we go 10 years forward and look backwards to today, we'd be amazed by the transition impact it is going to have. And algorithms, okay? So the other industries, telecom and finance, are largely run as industries on algorithms. They've got lots of algorithms running all the time on all their equipment that track everything, okay? And lots of decisions are made based on those algorithms. So I'll give you a couple examples in just a minute of the kinds of things you'll never know about that you may have benefited from, where algorithms are running those businesses. But in healthcare, we need to be thinking about terabytes of data a day, everything that, whether or not it's genomic device. In the next 5 to 10 years, we will be generating that much data. We need to do something with it. And I don't, seconds and sort of minutes are going to matter in healthcare. I'm not sure we're going to ever be in a nanosecond business, but the one thing that's really stands out, and that I'll make the claim of in a little bit, is there's way more need for algorithms in healthcare. And in fact, there's a greater supply of algorithms in healthcare than in any other industry I've met. To the orders of magnitude more algorithms and impact, opportunity for impact, than you'll see in finance and telecom. So it's quite a distinguishing characteristic. And this is one of the few industries. Telecom impacted a lot of lives. If you've gone to India, if you've gone to Indonesia, say, if you've gone to Tanzania or South Africa, and seen what a mobile phone has done, it's changed people's lives. It's changed the way business is done. Almost half of the commerce of Kenya is done on a mobile phone. Half of the commerce. There's no banks. All of the banks are basically on mobile phone networks. So they've had an impact. I think in healthcare we have a much more dramatic opportunity to touch people's lives and improve people's lives every day. And again, I think it's going to happen twice as fast as we've seen in the other industries. So for some of those, if there's techies in the room, or people dealing with data, most industries are capturing about 40 gigabytes per second of data. So you wonder how companies like trading companies capture data. They're capturing every piece of data in every commercial market all the time. So every single trade and every single packet is captured and persisted. But it's incredible, the volume. But what's interesting is this move to real time has brought with it something else, which is a continuous computing model. So if you trade in stocks, if you're a proprietary or a high frequency trading firm, you trade on every asset all the time, 24 hours a day. No matter what market is open, you continuously trade. And we don't think about that in healthcare yet. So, how many algorithms do we have running for a patient? Well, maybe a couple on admission, maybe a couple during their stay, a couple on discharge. What if we had thousands of algorithms running for all patients at every institution all the time? And that's the way the other industries think. We don't think that way in healthcare yet. And the value, what we found in the other industries is the data, a single data point doesn't matter. Lots of data points in context matter. And so just as an example, the telecom industry thought for a long time that your location, your latitude and longitude, two numbers, latitude and longitude, were really important, and they were going to be worth tens or hundreds of millions of dollars. Turns out they're not. The way you make latitude and longitude interesting is if you know it's that location is at home, at work, sitting next to, talking about, traveling across the or close to these goods. That's the contextual information about location is way more interesting than single data points. Okay, two numbers aren't very interesting. And so semantics, meaning, are way more important. Anybody everybody follow what Google's doing in terms of acquisitions? They basically bought every robotic company. Now, some would say, why? Some would say that's Skynet if you follow the Terminator movies. Why are they buying so many? It's actually not as much about the physical robotics. It's about reasoning. Okay? It's about understanding meaning in data. What do they have? They've got one of the largest collections of data in the world. And they're trying to make meaning, turn it into something that has meaning. So semantics are really what about the next 10 years. It turns out healthcare needs semantics. It needs meaning. It needs context. And obviously, in any industry, privacy is absolutely essential. So I'm going to now step back and just give you a couple of slides about what went on in the last 10 years in telecommunications. We've all enjoyed the benefits of a cell phone, but you may not know what's going on in the background in terms of the data. The problem, and we started this sort of notion about 10 years ago in the communication industry, this notion of a digital self. And you'll obviously see the analogies, I trust, as I go through the next couple of slides with where we're at in healthcare now, sort of at the beginning of a journey that the communication industry is largely going through. If you think about our digital selves, we leave little pieces of information, shards of information everywhere we go. And over the next 10 to 20 years, there will be shards of information about our health from lots of different things, all the devices we carry. The mobile phone that you have in your pocket or carry around will generate lots of health-related information. How active are you? Have you fallen? You know, those sorts of things. So there'll be lots and lots of data points that we'll be able to integrate and knit together. It won't be about a single data point, it'll be about bringing them together. But the problem with the mobile phone industry was, as you'll see in a minute, architecturally, there was lots of information spread everywhere about us and very little ability to integrate it. So the most important thing to communication companies, if you're Verizon, is retaining their customers. So just to give you a sense of impact, if you could change the retention rate, okay, for Verizon by 5%, so if you could increase, specifically, if you could increase customer retention. So if you don't like AT&T and you decide to go to Verizon, that's bad, okay? That's called churn. So you leave one carrier and you go to another. If you could change that by 5%, okay, it's a 75% increase in profitability. It's huge. A very, very small change makes an enormous impact on the outcome of the financials for a company like Verizon. Most people assume they could take one data point or a couple and determine how to retain customers. So they can say, well, customers obviously want a good voice experience, or they want a great, they want a convenient billing mechanism, or they want a better device. They want an iPhone or an Android phone. Turns out that very few data points give you anything. You've actually got to integrate lots of data points. Okay, so turns out, about a third of the experience and the retention tend to come from things like the handset you're carrying or the billing that you're using, that sort of thing. About a third come from the network, and so it's not one thing that determines outcome. It's many things in context. And so you've got to put together, unhappily, lots of data. So the industry in the communication business started integrating data over the last 10 years to try to determine what really was a good experience. And it wasn't until we woke up and figured out that, boy, it's not one data point, it's 1,000 that we're going to need to actually begin to make those decisions, that did our mindset change and the kind of infrastructure we're building change. So all industries, in my experience, go through 4 stages. Okay, and this is exactly the slide we used 10 years ago with our customers. Rick did the original research for it, as it turned out. But until you first recognize the value of the information and the data that underpins it, you don't go anywhere. And that is a human change. It takes people to understand that the data and the information that we can bring to bear have enormous impact. I think what we all may of our current federal administration, our current presidents, but the change in digitizing healthcare, the EMR, Obamacare, the digitization of healthcare has begun to make an enormous impact, I think, on our ability to make future decisions. Without it, there wouldn't have been an industry change here in the United States. I lived in Europe the last 15 years. Most of the rest of the European countries, certainly the northern European countries, are all digitized. Okay, so the healthcare records have been digitized for a long time. But it's not until you recognize that that data is going to deliver information and ultimately solutions, you begin to also make a transition. So we're beginning that process in healthcare. But then you've got to unify it. You've got to bring all those pieces together. Without 1,000 data points, you can't do a lot. I mean, you can't do a lot of interesting things. You can begin to start. But then you try to figure out how to actually profile somebody, and then you start exposing it to others and sharing it to build services. And this is exactly the stages that the industry went through. We proffered it 10 years ago. It's gone through that. So most of the telecommunication companies are here now. In fact, I will just soon join a board of a new company that is really a leader in the telecommunication industry in helping monetize that sort of data, figure out a way, both protecting personal privacy, but also making good use of it at scale. So the industry's pretty much in 10 years gone through that. So, a complicated picture, but you've got to take data and turn it into information and into insight, and then begin to apply it in business process. Most industries start by believing that data's valuable. It's not. Data's not valuable. Apply it to solving business problems, okay, human problems at the top. That's where the value is created. Every industry starts by believing that their data for, Verizon thinks, 10 years ago, certainly thought their data by itself was going to be really valuable. Then they figured out they had to put it together with Starbucks to make any money. If they didn't have Starbucks data and their data, they couldn't do much. So, and they couldn't help their customers, they couldn't do a lot of interesting things. So it takes time for people to understand that the more rapidly we understand that in healthcare, that it's not just the data that about a patient that the local clinic has, the local hospital, and the local home care network has, but the integration of that data is really quite key. So all the value ultimately is at the top of this stack, okay? So our ability to apply that information in terms of an actionable insight is where value is created. It's not, let's not confuse it with the core data. So just to give you a sense, by the way, my last company, go back to a slide, Lisa Kelly. We built an infrastructure that went top to bottom. Okay, so my last company sort of had an ability to aggregate, and this probably will sound familiar to you from a healthcare perspective. So the number of data sources when my last company got started in telecommunication, most companies like Verizon had about 200 different data sources that had little bits of information about each of us. They had a billing system, an SMS system, they had an email system, they had lots of different systems that all had little slivers of information. They couldn't integrate any of it, okay? So they were at a disadvantage in terms of understanding what we were doing as customers. But they were highly divergent data sources. So the first thing they had to do is build an infrastructure to integrate those. The second thing they had to do is change latitude and longitude into at home, at work, in the car sitting next to. And then eventually, you could begin to use that to solve business problems. So let me just give you a quick example of a business problem. So about 5 years ago, we could take every person in a major city, so something like Johannesburg, South Africa. In real time, meaning within a second or two, we could partition those customers as to which are quality sensitive and which are cost sensitive. Okay, so we could segment that population dynamically. We could take all of the cost-sensitive customers, determine their propensity to accept a discount. And what we do in South Africa is you tend to carry around your phone in a pocket full of SIM cards, the little thing that goes in the side of your phone. Because from 5 to 7 o'clock, this network was cheaper. And from 7 to 9, this one was cheaper. People literally pull out their SIM cards 3 to 4 times a day to manage the cost, because about 75% of South Africans are highly cost constrained. So it's very important to them to manage cost. So we could determine their propensity to accept the discount, when they would likely change their SIM card out. 10 minutes before they changed it, we'd send them a text message. If you stay on this network for the next 2 hours, we'll give you a 20% discount. That's marginal revenue. That would typically generate 30 to 50 million more dollars right off the top for an operator. Very easy. Now for quality sensitive customers, I don't know how many of you know, I don't know my cell phone. So this phone doesn't decide how much power to output. Okay, so it doesn't have like a 3-watt output. The network tells it how much power to output. Okay, and they do that for radio interference reasons. But if you're a quality sensitive customer, what we would do is we would tilt the antenna, because all of those big cell towers you see, all of the antennas are now tiltable. Okay, so we could tilt the antenna slightly more to the audience we wanted to serve. We can turn up the power in the handset. And so for quality sensitive customers, we could actually improve their quality of service. Now, imagine doing that continuously all the time. Those are just algorithms running to improve quality of service for those that were quality sensitive, and to reduce cost for those that were cost sensitive. But that's the kind of algorithms you can run at scale across a population for all people all the time. Again, we're not quite there yet in healthcare in terms of things. So, sorry guys, thank you. Let's skip that if we may. There's lots of opportunities for impact. I've talked about it. This is quite literally what, if you were at Verizon has Fios, I think, the cable offering. They've got a fixed network, they've got a mobile network, they've got wireless broadband, and they've got fixed broadband. They literally had hundreds of different databases, and what they had to figure out is how do we pull those together and integrate the information from not only within our business but across, and then build essentially a decision support layer in their infrastructure at scale. And so every major telecom company has gone through this now in the world. The same sort of infrastructure now exists in finance. So hundreds of streaming data sources all running into a decisioning infrastructure. And it's very different than the underlying EMRs. In every other industry, there are transaction-based systems that sit underneath that sort of decision infrastructure. They're never the same infrastructure. So I believe that what we'll see emerge is a decision layer of infrastructure that's going to sit above the data and transaction EMR layer in healthcare. So where does it now really become valuable? Okay, so all the values at the top, right, that ability to change the cost and the quality, it turns out you don't need one application. You need 10, or you need 100, or you need 1,000, because now you want to apply that same insight to customer care. So what if you could solve, and one of the previous examples which we skipped through, what if you could solve 98% of your customers' problems the first time in healthcare? They come to the doctor the first time, 98% of the problems you can solve the first visit. Well, that's what the data would allow us to do in telecommunications. We could solve for customer care, call Verizon and say, I have a problem. They could solve 98% of the problems on the first telephone call. Industry average was about 20%. Normally they take your call, go, we don't know what's going on, we'll have to call you back. And that's not the case anymore, but that's just an application, it's an algorithm. Turns out the need for algorithms scales hugely, meaning you need more and more and more. Now medicine's like that. You need endocrinology algorithms, you need cardiology algorithms, you need nephrology algorithms. Medicine's big, it's a huge piece. Pharmaceutical companies need adverse event algorithms. They need outcomes algorithms for their drugs. Payers need algorithms to detect fraud. They need algorithms to determine value. How much cost have we invested in this life? What kind of return are we getting from the healthcare system? So if you don't do something about the cost of infrastructure, your cost goes up linearly. You need more algorithms, more cost. That's unsustainable. Okay, and any industry became unsustainable in healthcare. So you ultimately have to find a way to bend that cost curve. Finance has done it. Telecom has done it. So they've built platforms, decision infrastructure that can sit across lots of divergent data streams and then allow you to start building new applications and algorithms at a fraction of the cost and a fraction of the time. And that's just what has to happen, I think, in healthcare. So ultimately it's about, today we're beginning to get most of the assets. We've got to turn it into actionable data. So let me tell you a little bit, I'm going to switch gears, tell you a little bit about what we're doing at Pervasive Health and how we kind of see the opportunity that we see for the transition of healthcare. So we're a young company, as described. Most of our team has come out of proprietary trading, so high frequency trading, which if you've seen any of there's been over the last 2 or 3 weeks a lot of bad press about it, that somehow high frequency trading is cheating the economic system. I don't happen to believe that from an economics point of view. But that infrastructure is trading, again, continuously. Lots of algorithms running all the time for every asset. And so what we're beginning to think about at Pervasive Health with what we call our Approvita platform is making healthcare computable. So what assets do we have that are computable or should be computable? Where do they live? And how do we make them collaborative? How do we begin to share them and develop them? So it turns out that healthcare, unlike telecom and finance, literally has millions and millions of algorithms. Okay, they're already built. Where do most of them live? They live in PubMed. Okay, they live in paper. So we've created algorithms which are substantially evidence-based that determine just about everything. Your risk for, risk for reoccurrence of cancer, risk for diabetes, risk for pretty much every disease. Surgical algorithms that determine the cutback margin for prostate cancer. So, given these conditions, what should we do? They live everywhere. There's quality measures, operational measures, blood bank management measures, and algorithms. So they really, sort of pun intended, I guess, are pervasive in healthcare. Unfortunately, they live in paper. Okay, so well more than 90% of all of the stuff that's been developed simply doesn't exist in a computable form. You can't take a pathway and make it computable readily. You can't take a protocol and make it computable readily, which means run it for all patients all the time. So just as an example, Mayo Clinic generates just in medical algorithms. Okay, this is not pathways, it's not protocols, it's not measures, it's not assessments, it's not nomograms, which are just other types of algorithms. But about 100 algorithms a year if you use PubMed as the reference, okay? So things like survival for a particular type of cancer, risk stratification for patients with a hip procedure. So now it turns out Mayo generates about twice as many as Cleveland Clinic, okay? So it's well ahead and probably is one of the greatest and most prolific developers of algorithms in the space. And it's growing about 30% a year. A lot of the intellectual property of this institution and other academic institutions is just not device or biologic, it's algorithms, okay? It's computable health capabilities. The problem is most of this ends up in PubMed as a piece of paper. It doesn't get translated into something that runs at scale and runs for all patients all the time. And we see that, we know that because a well-quoted sort of evidence says it takes 17 years. It turns out that somewhere between 12 and 15 years of that has nothing to do with research. It has to do with dissemination. Okay, it has to do with converting it to practice, which means something's wrong. We can't take an evidence piece of paper and turn it into something that's computable and runnable for a patient. So, in a sense, why? This is my example of what a data warehouse looks like in healthcare. It's a sort of an old building. It's literally a warehouse with lots. It's sort of PubMed. We put stuff there, but we don't know how to actually extract the knowledge that we've created as humans and apply it at scale. So, why aren't they pervasive? Well, it turns out that if you look at the tools and technologies to develop a set of algorithms in healthcare, it takes typically 2 to 3 years and $3 million. If you go to a proprietary an algorithmic trading firm, they have a trader and a software developer, a trader and a software developer, a trader and a software, literally sitting next to each other. They generate new algorithms in 15 minutes. They spot an opportunity, write some sophisticated math, okay, because it's a math-based problem. They then do something unique. They back solve it. They've got all the data for the last 30 years for every market trade that ever went on. They back solve the algorithm, so they go, looks like that pattern is repeatable. They then turn it loose. And then they see if it continues to work, and they gather new evidence about whether or not it's actually producing financial returns. And if it's not, they kill it. They build another one. So I'm not suggesting that we're ready for that in health yet, quite. But I can tell you that the time for translation of an idea and an evidence-based into something that is in practice operates in minutes in other industries. In healthcare, it takes 17 years. So something's wrong, right? Now, it's not, so if you talk about efficient markets, highly inefficient. So the production side of this intellectual property takes 17 years. It takes, to make it computable, it takes another $3 million. That's the number, think about the number of companies you can spin out with that kind of cost. Very few. They don't come, you're not going to get many companies out of an accelerator or out of any infrastructure. The problem's just as bad on the other side. If you want to acquire some of those medical algorithms, typically will take you a year to just integrate it. You got to integrate with Cerner, you got to integrate it with Epic, you got to integrate it with the claims database, you got to integrate it with the pharmaceutical management system, and it's going to cost you about $250,000 a year. So if you go to a company like the advisory board, they'll sell you a clinical decision support set of tools for about $250,000 a year that do comparative physician analysis, which means physician A is doing better than physician B or worse than physician B. And at that kind of cost point, how are you going to scale the number of algorithms? If we're indeed going to need 1,000 algorithms per patient per year in 5 years, and we're going to need 10,000 algorithms per patient per year in 10 years, these economics just don't work. Right, at all. So healthcare budgets, I think we all know, aren't getting any bigger. So and these are basically for single algorithms, for single insights. So the economics is broken. You can't produce them efficiently and cheaply, and you can't consume them cheaply. So something's got to change. And that's what we saw in telecom, which is more applications you need, you got to change the economic proposition. So turns out there's some hard problems. And with a good fortune for me, Mayo Clinic helped me find some of these. So we spent time with a number of leading institutions over the last 4 years as we prepared for Pervasive Health. And everybody's got the same problem. It's got this complex data problem. In telecom and in finance, the data's become reasonably similar. It's fairly structured. In healthcare, it's not yet structured. It's pretty complex. So that's a dimension that the other industries don't quite suffer from. So you've got to go solve that hard problem. There's no tools to build health insights. The reason you can turn in finance an algorithm into something that is computable and can run against every stock all the time in about 15 minutes is because there's a set of tools that speak finance algebra. It's a math. There is no math. There's no health algebra to build an insight today. So you got to find a pattern to make these things very easy to build and configurable and portable. And then there's no infrastructure on an enterprise basis to share. We all share tweets. We all share Facebook posts. We can't build an algorithm and share it from one institution to the next. If you want to take that piece of paper, so think about an algorithm that does something like sepsis detection. And it's one that's beginning to be made computable lots of places. So sepsis is particularly bad, right? It's an infection, or your body's immune response to an infection. It can kill you in a few hours. About 120,000 people a year die from sepsis. Not exclusively hospital acquired, but a substantial proportion of it is hospital acquired. Why isn't there? And there are good algorithms out there. For Mayo Clinic, if I'm not mistaken, Mayo just got a patent in the sepsis area recently, if I'm not mistaken, June. But why isn't there an algorithm that, if you can interdict, if you can see sepsis appearing in the clinical record, why isn't there an algorithm that's running for all patients all the time at every hospital? There should be, right? But Hospital A, Mayo Clinic, who invented that, can't share it with another hospital down the road. They have to re-implement it. Mayo has the infrastructure, the intellectual capability to re-implement those algorithms. The hospital down the road does not. So if we're going to make all this value that exists in health insights really readily available, we've got to find a way to share it. And then there's simply no industry solution. There's nobody yet that's saying, companies like Amazon are running lots of algorithms, and all of us, if any of us shop on Amazon, trying to determine what else you may want to buy, the recommendations. They're running algorithms to say, what email should I send? There's lots of algorithms running around every transaction we make with Google, every algorithm, lots of algorithms for everyone with Amazon. But there is no similar industry scale solution in healthcare where you can run an algorithm for all patients all the time, continuously at every institution. So those are problems you got to solve. So what if you could build an algorithm literally in a couple of days, if not hours? What if you could acquire it at 100 times less cost? So not $250,000 for an algorithm or a set of algorithms, small set, but you could acquire it for $2,500 or $25. Now that would change the economics sufficiently so you could run 1,000 algorithms for every patient and you could afford to acquire them. Because today, if you could take that cost and time out, you've got an efficient marketplace. And so that's how we thought about the need for an industry solution in healthcare, which is something that allows, and it's got to be self-service for professionals to be able to author algorithms, to be able to ultimately connect them to the complex healthcare data that exists, it's pharma data, provider data, claims data, and then to ultimately publish them, share them with another institution, and to make all of that self-service, allow all of that to happen almost instantly. So we thought there's an opportunity for a global industry scale platform. If you look at all the major trading platforms that exist, if we think about New York Stock Exchange, in Chicago we've got the Chicago Mercantile Exchange. The Chicago Mercantile Exchange, I forget, is 5 times bigger or something like that than the New York Stock Exchange in terms of the number of transactions they do. They run 7x24, they trade all the time. But there's nothing like that. There's no infrastructure in healthcare that can, again, support 100,000 enterprises running hundreds of thousands of algorithms. So, now, again, it exists in finance, it exists in telecommunications. Verizon is running hundreds of thousands of algorithms around all of us all the time. So, but there's nothing like that in health. And you want it to be collaborative. You want to be able to take something developed here at Mayo and share it with any other institution that would want to acquire some for social value, give it away. because it has an impact on people's lives. Some of it for commercial return to enrich this institution and perpetuate the good research that goes on here. So, but that's an institutional decision. And then it's got to be essentially self-service, and it's got to solve those hard problems that you saw on the other page. So what we're building as a company is fairly ambitious, as many people have told us, is essentially a new generation of platform. Okay, it's in the cloud. It is what we term as a platform as a service, meaning we build infrastructure to allow everyone else to build applications. We don't build a single algorithm, health algorithm. We build a platform to allow people to build health algorithms and then to run them, turn them loose at incredible scale. Okay, so we don't. Our view is that the community of academic medical centers and researchers and professionals and entrepreneurs in healthcare are going to win at the end of the day. The community is big enough worldwide because the U.S. doesn't have a exclusivity on health innovation. It goes on in Italy, it goes on in the UK, it goes on in Singapore, it goes on in Thailand, it goes on in China. That there's lots of health researchers, clinicians, entrepreneurs around the world that know how to take evidence-based research and turn it into something like an algorithm that can be run at scale. We think the community will always beat silo solutions. That as a world community of researchers and clinicians, we can absolutely deliver lots of content worldwide that in the next 10 years will be transformative. Almost every preventable adverse event, of which there's about 700, well, just preventable drug adverse events is I think about 700,000 according to HRQ. According to the IHI, there's 400,000 preventable adverse events. All of those should be interdictable in large measure. This kind of infrastructure, if the community can build it and other people can adopt and run it very quickly, should have a dramatic impact on health quality and on ultimately outcomes. And when I say dramatic, I mean 100 to 1,000-fold. Remember how long it used to take us to look up anything? We can look up anything we want in just a short period of 10 years. Google's made anything in the world accessible, virtually anything, right? So we can find it, search it, learn about it. Healthcare's got that opportunity in 10 years to literally 100 or 1,000 times improvement. And that's both reducing cost and accelerating scale and time to adoption. So that 17 years ought to be 17 days for lots of things. And then ultimately improving the quality of the outcome. So our platform, as I said, is available to others as a service. There's a set of tools for authors, people who build health content. So if you want to build a new quality measure, if you want to build a new health algorithm, if you want to build a new nomogram, if you want to build a new pathway and make it computable and turn it loose, you should be able to author it, package it, and distribute it safely and securely so the intellectual property is protected. So the institution or the individual that brings that should absolutely retain rights to it. We don't own anything, we don't license it, we allow people to make and really license their own intellectual property to other institutions, but you need a way to do that. And then you need a way to openly share it, use it just about anywhere. So rather than a closed systems approach where if you embed something in the traditional EHR in the provider sector today, you can't get something out of Cerner and run it in Epic. You can't get something out of Epic and run it in Intermountain. You just can't do that. You need an infrastructure, in this case, that will allow that to happen so that you can run something just about anywhere. And so our infrastructure will do that, so you can run it off the platform, you can run it on the platform, you can run it in a mobile context. And we think that will be transformative because the value of the content and all of those algorithms is only impactful if it gets into the workflow. So we want to be in the workflow and allow authors to put their content into the workflow everywhere. So just a simple example. So there's a hospitalist and a researcher at the University of Chicago. Her name is Dr. Donna Edelson. She's built a suite of algorithms. Mayo, I know, has built algorithms that are not dissimilar. That basically it's with great sensitivity and specificity that will basically provide a 48-hour forward indication of a heart attack or other cardiac arrest event that will predict an ICU stay, which means in the next 48 hours this patient's likely to go to the ICU, and of death. They're good enough to run a commercial operation on, meaning that the algorithms' results from an evidence perspective and an accuracy perspective are extremely good and good enough to run a rapid things like a rapid response team. Well, traditionally, she was thinking about starting a new business. It was going to take her about 2 years. She'd have to raise a couple $1 million to build a one-off solution to make those available. She's been able to use our platform to build that algorithm in less than 3 months. In fact, it's actually taken a couple of weeks to do. She's been working on the evidence set for it over a little longer period. She's made no capital investment, zero. She didn't have to raise $2 or $3 million. Okay, people like Jim like that. Highly cost efficient, right? You can do lots of these things. You don't have to put much capital work up front. And then she could start offering it to other hospitals. Her only interest in making those algorithms available is to impact the 200,000 people's lives a year in which this algorithm would allow a clinician to intercede early and stave off, ideally permanently, but certainly for a short term, any of those bad events. Now, every one of these bad events, a heart attack, an ICU stay, is a could be $100,000 cost. So if we can avoid the cost, it's good for the healthcare system, it's good for the payer, obviously good for the person, right? If we can avoid those events. So she's now able to take this out literally after a number of effectively weeks in this case now and make that available at every healthcare institution on the planet. That wasn't simply possible a couple of years ago. So when we talk about computable content, and a little hard to read, there's lots of types of content. So I described a few, but Mayo here creates population definitions. What is a population of diabetic patients? What is a population of asthmatic patients? Well, that's a little hard to figure out. So you've got to have deep clinical knowledge. So if you can do that, you can begin to capture good specifications of simply target populations and use those repeatedly. That's a knowledge base that needs to be developed and disseminated. That doesn't exist in the marketplace today. Every institution, and in fact, I would argue, every researcher at every institution has a different, at work in diabetes, have a different definition of a diabetic population. There's just no standard. So there needs to be, if we're going to treat and do analytics on diabetic populations, Mayo Clinic develops a lot of that content. Then there's algorithms and scores and quality measures, but again, millions of these things, plus the data sets themselves. Our platform exists today. Again, we're a young company. So we've been through now a year of scale pilots, and actually it's commercial in service at some large healthcare institutions where we're able to build a set of algorithms, usually 10 to 20 lines of script, highly sophisticated, but it's a health algebra. It's a script that takes health logic and turns it into a health algorithm. That 10 or 20 lines of code replaces 200,000 lines of code. Okay, so your choice is to take 2 years and write 200,000 lines or 10 lines. So dramatically different in terms of what it is. You can then put it into a marketplace with all of the evidence that backs it up. Somebody else can acquire it, build a dashboard, and apply it literally in minutes. So then you can run it at scale. You can literally set it up to run for all patients all the time, and then do whatever you want with the output. You can run it into your EMR, you can run it into a mobile handset, you can run it into a website. So I'll give you a data example. So many of you might be familiar with Leapfrog. They do hospital safety and quality. They're bringing their data onto our platform. They're making it available for commercialization. Now, why? Every major health plan, every major health information exchange, every health insurance exchange wants access to that hospital safety data. One more view. And what they want to do with it is, every health plan wants that safety grade on their on their website, because their evidence, Leapfrog's evidence, would suggest that an A or B grade, as opposed to a C, D, or F grade, is the difference between 50% greater likelihood of mortality and 50% greater cost. So, none of us, I trust, want to go to a hospital that's going to have a poor outcome. So, and that's just more likely in a C, D, or F hospital. So everybody wants this information. They have no way to take that product and make it available everywhere. So in this example, essentially our platform is serving that up. Every time it gets served up, Leapfrog makes a little bit of money. Okay? It's much like Google. Every time an ad is served up, they make a little bit of money. So in this case, this is a public domain example. Our platform supports private domain in secure private healthcare information, but there's lots of uses for it, is my point. Uses you might not immediately consider. Here's the same thing on an AARP webpage where a hospital, as we all get older, and I'm just about to be a member of AARP, is you can essentially search for a hospital. Again, that's served upon our platform. So there's lots of ways you can use this in a non-clinical setting in addition. So imagine a future where you've got computable health at scale, where you're running thousands or tens of thousands of insights for all, every person all the time, and the impact that can have. We think it's going to be dramatic. For those of you that are health entrepreneurs, I've been in lots of other industries, as I've described, over my tenure. Think about this. We spend $3 to $4 billion a year in healthcare here in the United States, $1 trillion in healthcare in the United States. Let's assume that 30 to 50% of that is waste, and there's good evidence that would suggest it's somewhere in that sort of range. $3 trillion, let's make 30% to 33% to the lower end. That's about $1 trillion of waste in the healthcare system. Now, Mayo is a pioneer in carving that waste out. Most other institutions do not. That is 1,000 $1 billion market segments. Every one of those items of waste. So that is the largest collection of new business opportunities I have ever met in my entire career. I don't think there's ever been a market that is as ripe for entrepreneurship as the healthcare market is. That is $1,000 billion market segments. Most venture capitalists would be happy with a $100 million or $500 million market, a $1 billion market. In fact, $1,000 billion markets, and I would argue it's actually a lot bigger because that's only the US, so scale that globally. So there is the biggest opportunity, I think, to impact society and us as humans and improve outcomes that we've ever seen. There's not healthcare is at a scale of opportunity that's literally unmatched in what we've ever seen. The whole telecom industry worldwide is about $1 trillion industry. So every mobile phone from everything's about $1 trillion. Healthcare, round numbers globally, is $7 to $10 trillion. It's 10 times bigger than the entire mobile phone industry. And we impacted a lot of people's lives in telecom with phones. I think the opportunity in healthcare and with this kind of thinking and infrastructure has an opportunity to impact a lot more people's lives to the better, as well as dramatically address those sort of trillions or trillions of dollars worth of markets. So it's a heck of a good time to be an entrepreneur. It's a heck of a good time to think about how we build, share, collaborate around these kinds of insights, and then we need to now let them loose and deploy them so they run for everybody all the time. So that's it. A little bit of retrospective on telecommunications and finance, and I think some things we could learn and the opportunities that exist. Questions, thoughts? Intriguing, relevant, not interesting.
Cool stuff.
Who's using the platform now?
So we've got a number of health systems in the NHS today. So we operate in the UK. We've got a small team there. So they're everything from ICUs on the real-time end on the trust side to the other end, which is mental health management. But they run lots of algorithms for triaging patients in mental health, and that's one way they address costs. So we're beginning to deploy here in the United States with primary care, interestingly enough, because it's very hard to aggregate the data for primary care and then run these kinds of services. They just don't simply have the cost-effective infrastructure to build a data warehouse at a small or mid-sized group practice. We will start to deploy with some larger institutions later this year. So again, we're quite young.
Do you have like a video, like a deep dive video on your website on your technology and everything? Because I'm really interested into the details. Like, what does the author provide? What do you provide? Like, do you provide standardization of data or not? Do you provide the interfaces to Cerner or whatsoever or not? And so.
Great question. We do not today. That is coming. So mid-year, within about the next 2 months, we'll release what we term our self-service release. So all the tools we've been using to build this sort of infrastructure, like in the NHS, we're letting loose for everybody else. And at that point, we'll make those available. To answer your question, the magic is when we handle that complex data problem. So we make that standardization very easy. So you can literally, as other industries, you can throw any data in it.
But you don't do it. Like, for example, you don't force, let's say, the ontology that Mayo Clinic uses on Cleveland Clinic.
That is correct. That is correct. So you can choose your ontologies, and hopefully, if there's a commonality there, you can also leverage that.
Okay.
But be happy to share more with you.
I'm a physician, so, you know, you can disregard everything I say. I recently retired, so I feel like I can say anything I want to say. I have three areas that I'd like to ask you about. The first is you mentioned evidence-based. It's like it's a rock-solid foundation. It's not.
Yep, it's Swiss cheese.
It's,
I describe it as.
yeah, I mean, level B, level C evidence, the preponderance, cohort studies, case series is vast, you know. So how can you build usable, effective algorithms on this sort of shaky foundation? Second thing.
Okay.
Um,
Go on.
you talk about, or maybe I'm just interpreting, that medicine is like GM, you know, a Chevy Cobalt has a faulty switch, and we just change all these switches. We go by the algorithm, and it gets the problem fixed. And I would say after 32 years, and you know, if that were the case, then you're not gonna need people like me. Because anybody can just put a patient on an algorithm and there's gonna be a good outcome. But we all know that doesn't happen.
Yep.
Because people are not bankers, and they don't all respond, if you will, in the same way. That's another problem I have. The last problem I have, well, let me just back up a little bit. What I worry about is that I come up with an algorithm that says rotten strawberries are good for prostate cancer. And I put it on your network, and there's no validation, no standardization. I mean, Mayo has gone in great leaps and bounds recently in standardization, and I've been a part of that before I retired, and I understand that, and it's worked. But that doesn't mean it's going to work everywhere, and it doesn't, and it works here, but the generalization of it, I wonder about. So the validation part of it.
Yep.
Finally, privacy. Tell me what your definition of privacy is, because if you know I have hypertension and diabetes and hepatitis C, and all these other people know it, I don't consider that private.
Yeah. Wow.
And
Mr. Chief K.
the liability.
Great set of questions. So take them one at a time, see if I remember. So the Swiss cheese of evidence, okay? You know what, again, my wife is a physician, I came to healthcare. I was shocked to find how disparate lots of the evidence sets are, right? How unattached, and how much we don't know, okay? So the reason for the thought process, and the way the other industries have begun to do that is, first, they've got a comprehensive data set. So you can start with a hypothesis and you can test it quickly. And that means having enough data to begin to at least start. That's half the process, evidence to practice. What you then tend to do is, and it's true in certainly finance and telecom now, is you start to run the algorithm, and then you see how good it actually is. And so you take the practice back to evidence, because every execution of the algorithm collects the evidence, and you can begin to connect it in a way you can't. So one of the things we're trying to build with this platform is the ability for an author like that, Donna Edelson, to get her data back from every execution from every other institution, if the consumer, meaning the institution that acquires it, allows her to. Now, she's not getting back identifiable patient data, but she's getting some measure of success with that, so she can extend her evidence set.
Let me just ask you one thing on that. Let's say her algorithm is a total disaster.
Yep.
She has a 50% mortality rate with that. What's the liability issue for you, for her?
Very good question. So, the short answer is, if she publishes that work today in a peer-reviewed journal, she's got liability, which is credentialed. There's a big difference, I think, in the opportunity for application, which is simply deciding, like GM with the parts, what I call a retrospective assessment, which is starting somewhere and saying, how many places might we have intervened that we didn't, that we could start improving our quality process? okay? So you don't have to move to interdictive, which is letting the algorithm actually tell you what to do. Okay, that's a step. Once you've got an evidence set and a confidence that it's highly replicable and impactful in a positive way, not a negative way. So that's a learning process and a progression. And most of the progression goes retrospective analysis, how big's the problem, to prospective, meaning these are the 6 patients from a risk stratification perspective that we ought to look at the next shift. But it's not yet making a clinical decision. And then only then, after the evidence base develops, do you apply it interdictively, which means it's actually supporting the decision support process. That process usually takes a number of years. By the way, every other industry goes through that. Finance has just perfected it. By the way, lots of finance algorithms do go wrong. The reason it's a trader and a person, do you know that most of the traders don't do any trading anymore? They literally sit with a big kill switch, and they just watch it. If the algorithm goes wrong, they stop it. But so they rely on a human. Now, to your second point, what about the, in a sense, the automation sort of piece? So I don't believe personally algorithms are going to replace people in medicine anytime soon. Okay, they're going to become assistant tools. I used to work for Boeing. I wrote all the test software for the KC-135 tanker. I wrote all the test software for the B-1 bomber. So it turns out if you get the software wrong, okay, bad things happen. So the airline industry and the FAA over a number of years have dramatically improved the safety of the whole industry. Most of it, interestingly enough, has come from flight cockpit software, which is specifically autopilot. That autopilot software now, a plane is generally on 80+% of the time using that automated software. And crashes have gone down dramatically because what is taken out is the human error. Now, I will not fly on a drone, personally. I'm not sure that's going to happen in my lifetime. I want a pilot in the front seat. I want a physician in the front seat, okay, personally. So, because there's a lot about Swiss cheese to start with, a lot we don't know. And it's the human intuition and the connectedness we're able to make as humans that machines aren't good at. So I see these algorithms and running them at scale, not as replacing physicians, but as assistive. It just helps us make less human mistakes by picking up more things, just like the automated flight test system. Evidence standard. So for this, and for Pervasive certainly to be successful, we've got to have a trusted level of content that others produce. So what we can't do is what Google has done with its Android App Store. Let anything in, of which some would say 70% is malware, it's bad. Apple doesn't quite have that problem. They have a curated set of apps in the App Store. So this has even a higher standard. You've got to make sure that the content comes with an evidence base. And the only way you'll be able to, in a sense, publish globally is with good sets of evidence. Don Edison has now 10 years and hundreds and hundreds and hundreds of thousands of patients with the data. And she would tell you that you start retrospectively, then you go prospectively. It's intended for interdictive, but it's not something that you would go apply. So this, my view generally, if you look forward, most people, it's not like the App Store where there's going to be 100,000 Acme cardiology algorithms. It's just not going to happen. I think a majority of the content in the future is going to come from places like Mayo Clinic. I think Mayo Clinic or Imperial in London are going to be the trust standard. So very different than the App Store where there's 100 apps in any one category. I think there's only going to be 2 or 3 for the hospital down the street to choose from. They're going to choose, the Imperial lot or the Mayo lot because the institution here has got the ability to do the synthesis, the evidence development that most people can't. So we don't believe in an Acme model.
So,
I'm sorry, go ahead. Go.
are you going to have within your company some review section that will say, yeah, I don't think so. Yeah, this is good.
Very good question. So we will have a standard for clinical evidence that's a minimum threshold we've got to meet. So it's got to be published, it's got to be peer reviewed. So a minimum standard, okay? Beyond that, we want, okay, and we think the only people who can do that are the professional societies. We think the American College of Cardiology are the people who are going to set the gold standard based on an aggregate evidence set. And so our sense is that the curation of what's good and what's meaningful should come from the practice-based evidence, like the performance of the algorithm that's been aggregated over a long period of time, plus the evidence that came in, plus insight that a professional society brings. So we want to make the professional societies active curators. They do it today, right? They have a website full of clinical guidelines. They're just not into computable content yet. They want to be, because we talk to most of them,
Yeah.
but they don't quite have the facilities to do it.
Privacy?
So last question, privacy. So privacy, this is a HIPAA secure, absolutely private platform. The truth is that we're thinking about this considerably differently than what you would do in telecom. In telecom, you can take location data, the name off, and send it out. It may be identifiable, as much of it is, the likelihood of finding somebody small. As you point out, it's much easier to identify somebody in this healthcare data than exists. So, sort of two approaches. One is, for the pharmaceutical company that wants to say, follow adverse events for my medication without, so today, what happens is, people like Humedica take data from Mayo Clinic and sell it to the pharma, and hopefully it's de-identified, okay? Our view of the future is just the opposite, which is Pfizer builds a secure algorithm that's credentialed, that is run at Mayo Clinic, that simply produces statistical results of the number of incidents of adverse events based on its definition. The algorithm moves to Mayo, the data doesn't move to Pfizer, okay? So it's a completely different model. Second is, what you've got to you've got to start as a healthcare secure platform, but then we do think that larger and larger data sets are more and more important to healthcare. So allowing institutions to aggregate those in larger data sets, but allow them to do that through security identification mechanisms with the best of our statistical ability today. There's nothing that's perfect. There's an organization, for instance, which is attached to the University of Chicago, which is bringing a set of algorithms on our platform that meets the CMS standard for de-identification. They take all of the CMS claims. It's an organization called NRC, but they produce the de-identification algorithms. They're making those algorithms available on our platform so that data set owners can say, I want to contribute in a truly de-identified way, again, to the best of our statistical ability, those data sets so they can be aggregated for larger research. We think that's key because, again, larger data sets make for better research over time. So there's no perfect answer other than a very structured approach that starts with assuming this is highly private data and then only moves from there when there's, in a sense, good evidence. So.
Great questions. Others?
Other questions?
I guess, going back to the data part, I'm still curious how you are envisioning getting the data in, especially that's typically been a very sort of privately held thing. So my first question is, what's your lobbying budget, to get these people motivated to do it? I mean, that's what it took back in the day, for ACR and NEMO basically to come up and say, if you don't produce a common standard of exchange of this kind of information, we won't buy you. And I think you've got that problem, and you've got the context of the algorithms too. You mentioned it early on. You've got a person that's working in Chicago that is, identified, let's say, an algorithm that you mentioned for sepsis. Well, that algorithm may be completely different in an area that's, let's say third world, where the first thing you're looking at is what water do they drink.
Yeah.
Right. So how are you gonna? It's not just a healthcare problem now; it's also a lifestyle problem. So you have to create a situation where you've got not only the data they're getting in their healthcare institution, but basically all the telecom data that you've been talking about as well.
Yep. And it's both the scary part of this kind of business, but to some extent, where the opportunity lies. It's about the integration of data altogether. Google is integrating an incredible number of data sources semantically to know what we do. And I don't know if you've all watched Google and how good the searches get. They're generally getting pretty good, and in some cases a little scary.
But it's actually interesting that you mentioned that, because you can take Google, and if that you never let anybody else touch your computer, it gets pretty good. But if my 5-year-old gets on there, you get a completely different set of things, right?
Yeah.
And so that's what I'm sort of getting at, is how are you going to get the context of who's really operating the computer?
It's a very, very good question. I think the honest answer is I don't know yet. Okay. My sense is that Certainly for some well-structured environments, like general care wards for hospitals worldwide, Western hospitals worldwide, that they will need to be able to determine the applicability of those algorithms, and in part take them, run them, or run 3 or 6 of them and go, that one's a lot better. So for something like early warning, like the cardiac sort of things, so there's Donna's algorithm, there's news, there's views, there's pews, there's views. There's already a bunch of public domain ones. Which one's better? Run them all, figure out. So you don't have to make that hard choice and spend $250,000 and go, that didn't quite work for my circumstance. Run them. So I think for the first, I think we're going to start in a more structured environment where there's less variability, less need for context. I think as we grow over time, there's definitely, what will device data add to this? Don't know yet. What will circumstance, the social context, social determinants? Don't know yet. So there's no question there's going to be more data that's needed. In terms of sharing, what I see, a big piece of what's driven other industries is exactly what you said, which is first an acknowledgement that you've got to create some platform for sharing of this. I will tell you, every clinical researcher I've met has said, give me a bigger data set. If I can only have more data from more institutions, I can improve my practice and impact. And so I think the desire exists here in healthcare to do that in a significant way. It comes back to the privacy issue, which is, can you really begin to allow institutions to knit these things together in bigger and bigger sets? And can you produce data from the running of the algorithms themselves? Because that's additive to this. I think that's possible, and in this next 5 to 10 years, very possible in healthcare because there's such a strong demand. I don't think it's going to come overnight. It's been what seems to have stood in the way, in my opinion, is what is literally reasonably probably short-sightedness that somehow that data set is going to make a big difference, particularly if it's identified to the competitiveness of Mayo in this market. No, it's really not, and that's what Telecom learned is. And by the way, that's what every hedge fund in the United States, hedge funds, by the way, generally private, so until most recently they haven't had to publish any data. So they had no data. Guess what they did? They formed a consortium, they all set their data in, then they could buy it back. And healthcare generally wants to do that as well. I would assert the need is just as big. So I think we'll begin to find a way. I generally see that short-sightedness completely disappear. Not slowly, quite, institutions go, boy, we got to begin to figure out a way to share this stuff if we're really going to make an impact on the value chain of care. So,
But great question.
So
oh,
your model is kind of being that broker of the transactions.
Yes.
From a revenue stream perspective, you're collecting transactions as things go back and forth.
Correct.
You use the Google example, and using your sepsis sniffer app as an example.
Yep.
If I go out to Google, I can go buy advertising there and I can go promote my product to the top of the list when it comes to a search engine.
Yep.
Are you taking the same approach, or are you going to try to be a neutral arbiter of different competing algorithms in that marketplace?
We're generally going to allow evidence to drive things to the top of the list, which means who's got the best evidence set. So rather than being purely commercially driven, which says you can buy a place at the top of Facebook, we don't want to do that. We generally want to buy it based on who's got the best evidence, who's running the most, who's seeing the best results. That should what propagates you to the top and be featured, not because trust is key, not the ability to simply pay marketing dollars.
But depending on what your revenue stream is, that's one approach that others have taken, Amazon, Google, etc.
Yeah.
To be able to sustain themselves.
Generally, we will take a transaction fee, so we really do want to be in Switzerland. We just want to be a neutral arbiter, allowing so volume is good for us. And just like you see with Google and Amazon, everything they do makes it cheaper and cheaper and cheaper. So we really want to allow this infrastructure to get bigger and bigger, but cheaper and cheaper per execution. So, but a small amount of a large number of transactions is a lot.
So with those competitors coming to your marketplace, are you bringing them together to build a collaborative? Are you just going to stay out of it and let the marketplace dictate what gets accepted?
Short answer, don't quite know yet. What we're trying to do now is basically only engage those leading institutions that have good quality content. In some cases, we're seeing them form natural associations. So Tom Edelson, again, just to go back to her as an example, she knows the other 6 things that you typically want to do for not just early warning, but total acute management. And so she knows she doesn't have all of those algorithms, so she's naturally self-selecting her cohort and saying, these 6 things ought to be in. My colleague over there has, the 4 at Partners Healthcare. So, and so there's, to some extent, we see a little bit of that already happening where the authors are determining who they want to peer with and collaborate with to create bundles of content.
But
we're early on that.
your stance as Pervasive Health is that you're going to maintain this a neutral stance.
A neutral, as long as it meets a high standard of evidence.
Sort of going back to the validity of what is being put in there, being used. For instance, a lot of the control trials are done sort of with a control experiment of sorts in terms of you have an inclusion exclusion criteria, and then what population it works for, and then what medication they're on, what other socioeconomic factors that come into play for mental health, for instance, and if that's all going to be used. How do you ensure, is it going to be as simple as a disclaimer, or how do you ensure that who is going to use it down the road, they're using it for the right cohort, the right population, to start, used on the right patient group, the patient group, so that, one, you don't have any kind of, misuse intentionally or unintentionally.
Very, very good question. One is, in a sense, caveat emptor. We're not, we can't protect somebody from doing something bad with what we can do is make sure that there is a strong, clear definition of what that intellectual property is, that algorithm, and where it applies, where the evidence would suggest it should be applied. That's got to be very express. We've got to leave it in the clinical setting, we think, to the ultimately, the medical executive staff to make a decision. Today, medical executive staffs and providers decide, these 6, this is how we're going to practice, this is our standard. I would hope that they'll run these algorithms through their medical executive process. They'll go, we don't want the Cleveland ones, we want the Mayo ones, because we think it fits our population in a more definitive way than others. And so we don't want to, in a sense, try to replace that reasoning for what good sound process that exists today. I will suggest in the device space, in the payer space, there'll be a different set of decision criteria, right? Because they have different motivations. I want to provide enough information so you can make a sound decision on application of that algorithm. But ultimately, it's got to be up to the acquiring institution to wisely apply it. So this is not going to be something for consumers, where consumers can say, God, these 6 algorithms kind of sound good. They look like my condition. This is a professional business-to-business platform where professional authors like Mayo Clinic will engage with the Baylor Healths of the world who want to acquire that content. So I'm making that up.
And sort of related to that in terms of, some of this is still in the research stage because it's an ongoing learning, even these algorithm protocols, because it's an ongoing thing, and trying to better understand the disease states and how it progresses and what happens and so on. So even from even getting other institutions to use it is actually to, in a way, to sort of inform the algorithm. So what is the feedback loop in terms of, you've thought about to say, somebody uses the algorithm and then does the intervention for the patient in terms of prescription or intermittent treatment or whatever. How do you feed the outcomes back into the algorithm for the...
Absolutely excellent question. So what we could show you is we built effectively a couple of forms of a sharing mechanism. Okay, so one sharing mechanism is you built an algorithm. You can bring a couple of collaborating institutions into the same workspace. You can allow that collaborative to integrate on a de-identified basis their data. And if you want to participate in the collaborative, the better the research. And the collaborative, in effect, a PI as an example, could, as they recruit more members, could test the data, the algorithm gets larger and larger data sets. That's a basic process that goes on every day, right? You collect your cohort of other institutions. What we want to do is make that really easy to get a 6th, and 7th, and an 8th, and a 9th institution to simply say, oh yeah, that's a push of a button. I can add my data to that data set, not fear. Okay? Because the data doesn't go to Mayo Clinic, it goes, you know, as if that organization wants to detach themselves, they can do that. The other piece is a specific set of, in a sense, adjunct algorithms that determine efficacy. Right? They can run in parallel with the core algorithm, and those algorithms, we think the output of that should be routable back to the original author. Okay, so what you get is you get the algorithm. If you say, I want to participate in the research project attached to this on a large scale, I can run these other algorithms, and you can know safely those algorithms won't disclose personally identifiable data, but they will give you some research results that the original author can use to extend essentially their information. So that closing the loop of practice to evidence, in a sense, is very much, and what we certainly in academic institutions, the number one thing authors ask us for is, please can we have a bigger data set, or please can I find a way to get the results back to me? Because I just want to improve it. I don't care about making money. Many of them tell us they want to improve their data set, improve the algorithm, to improve the impact of people's lives. So those are the two core mechanisms that we've either built in or building in, as the case may be, to the platform.
Yeah, that's exactly where I was with the question. So do you keep yourselves have the patient identifiable information?
No, we have no access. We have no access to
That's-
institutions' data.
Yeah, that's the place where the problem comes in, is because, so you got a patient that's seen at one institution and then move on to another institution. I mean, a whole lot of people that come to Mayo Clinic have been treated somewhere else first, and then they come to Mayo Clinic, and their information may be coming from two different sources, the same person,
Yeah, it's not
with
statistically
information coming from
independent.
multiple sources.
No, in fact, the reason we started to deal with small primary care clinics here in the United States is because of that matching problem. So what we're actually doing is it's groups of associated institutions and their large hospitals. Now, we're doing that with a couple academic medical centers and quite a few critical access hospitals, because the critical problem they have is not being able to put the patient data together and match it to get a stronger. And generally what they're doing now is, particularly in Illinois, there's a consent process that allows that patient to essentially allow that data to flow between institutions. So those institutions can begin to put together the records. We're at the early stage, okay, of allowing them to link those records wisely together to determine that it's the same patient, and then to allow that integrated record to be made available. And to the point about context before, that's a big first step of context, right? Unless you can create more and more data that you know is the same person, you've got snippets, so it's as bad as the Swiss cheese research problem. You've got the data for here at Mayo Clinic, not all the chronic care condition stuff that exists at their GP. So as we grow, we hope it's easy enough for institutions to link their data so that patient data can begin to form that larger longitudinal record. So, but again, that'll come over the next 5 to 10 years, right? That's going to happen not overnight, but it's critical. It's definitely critical.
So,
And you guys, you can stay as long. I'll answer questions in one of my voices.
it's kind of cool actually to pick on this, but so he brought up the good point of it may be the same patient, but one of the things that happens in all research is that heavy screening of your subject pool. And how are you going to deal with what I'll call data dependencies? This person is presenting with this set of symptoms and you're extracting a section of that set of symptoms. How are you going to keep that tie back into the original uncertainty? So you've got, whenever you're doing like a NOVA, just keep going down the line, you have to take into account all those kind of things. And while I'm not a big fan of all that.
Yeah, that's a really good question.
Yeah.
So the way we built the infrastructure is, if you build these, what we would term drive cohorts, you can build those, but they always go back to the underlying cohort. So you can, if you're allowed, right, that you can pierce that and go back to the original, so you've got all the context. So if you're starting with simple inclusion, exclusion, and abstracting that population, so at some points you need to punch back through to all of them. So our drive populations are not actual populations. They're specifications that operate so that they always exist on that underlying data. And there's a bunch of different types of those. We can talk about it perhaps another time. But there are times when you want to freeze all the patient identifiers because You want to allow the data to change, but not the identifiers. That's a trial cohort, right? So you've got to be able to handle all those things. And we generally have approached them from, that's why we don't think, nobody in the enterprise sectors we think is going to do what we're doing, because there's so much health context that this isn't a problem for a general enterprise platform. You've got to be able to think about the problems like that.
So we absolutely do appreciate your time. Paul's voice is dying very much. Both Jasmine and Rick and myself are available for questions. We absolutely thank you very much for your time. If there's anything that you'd like to discuss offline, we'd be more than happy to do that.
We're recruiting authors.
Yes, we are recruiting authors. But thank you for the opportunity.